I don't know if you can see. Or do you mind sharing really quick? Hold on, all right. Very good afternoon. So today you're here for the Understanding Prostate Cancer workshop, hosted online and in person. We will be joined by Dr. Desiree Sanchez and Dr. Katigan, and they will be presenting on prevention, screening, and treatment methods. Before we get started, just a few announcements. We do have a new support group starting called Writing Alone Together. So it'll be a journaling group, a short term, about 6 weeks. And I'll have flyers out if you are interested. We have our Bold to Strike Out Cancer fundraiser coming up. So that's with the Ventura Downtown Lions Club. It'll be on February 28th from 12:30 to 3:30. And $35 will get you 3 games, a barbecue lunch, and then a event t-shirt, and then there'll be music, and food, and everything like that.
Good deal.
And then since you're here, we do have a prostate cancer networking group, if you aren't already aware, and a support group. So the networking group is for bringing family and friends, and then the support group is just for the patient. If you're interested, you can see me after. If you're not already joined, I can help you get signed up. And then there is a survey in front of you, and for those that are joining online, I'll send out that survey so you can fill it after the end of the presentation. And then I will let Dr. Katigan and Dr. Sanchez get to it. Thank you.
Thank you.
Okay, hello guys. I'm Dr. Katavian. I'm joined by my colleague, Dr. Sanchez, who's right next to me. We're both urologists at Simi Valley Adventist. We take care of a lot of patients with prostate cancer, and we're happy to speak to you guys today. There's a couple things on our agenda. One of them is just epidemiology and risks. We're going to talk about early detection of prostate cancer, screening, and then benefits of harms associated with prostate cancer detection. We'll talk about prevention, treatment, and then we'll have time for questions. So what is the prostate? This is actually like a very good question. All men have prostate glands. It sits beneath the bladder. Its responsibility is mainly to make ejaculatory fluid. The urethra travels through the prostate, so men can develop urinary symptoms related to prostate enlargement or growth. And prostate is also the #1 cause of cancer in men. It's also the second leading cause of cancer-related death in men. About 1 out of 10 guys are going to be diagnosed with prostate cancer in their lifetime. 2.5% of those guys may die from prostate cancer. Why? So this is the reason why it's important to screen. And then most cases, about 60% are diagnosed in men that are over 65 years old.
One thing I'll add to that is the age that you are is the percent chance that you have of having prostate cancer. So if you're 70 years old, there's probably a 70% chance that you have some small focus of even a tiny amount of prostate cancer in your prostate. So it's important for us to screen as men kind of past the age of 50 in particular.
Excellent point. So what are our risk factors? So these are the biggest risk factors for developing prostate cancer. Am I in your guys' way, by the way? I'm probably in your way. You can go over here. So African ancestry is a leading cause of risk. Men that are of African ancestry also have a higher risk of having more aggressive prostate cancer, so we started screening earlier. If you have a family history of prostate cancer, breast, ovarian, or pancreatic, those have been associated with developing prostate cancer. There's now these new genetic risk scoring testing that's being done where they actually look at your full genome sequence and try to find if there's like specific non-coding regions that are associated with prostate cancer, and you can be given higher risk scores. And then there's germline mutations that are passed down hereditary. These are the most notable ones are BRCA1, BRCA2. These are associated with breast cancer. So what are the symptoms of prostate cancer? So believe it or not, most men are asymptomatic. So usually when I give patients a new diagnosis, they say, well, I feel fine. How do I have cancer if I feel fine? Well, most patients don't have symptoms. That's the reason we actually screen for prostate cancer, is we're trying to find prostate cancer in asymptomatic population that if we did treatment on could benefit it and live longer. Some people think that prostate cancer is associated with urinary symptoms. So like, oh, I'm peeing more often, I'm getting older, maybe those reasons are why I'm developing prostate cancer. There's actually been no link or association between prostate cancer and developing urinary symptoms. And then sometimes, this is not all the time, but 10% of new diagnosed patients with prostate cancer present with metastatic disease. So if you have metastatic disease, sometimes that presents with bone type symptoms, so bone pain or even pathologic fractures. So, but that's not as common. So how do we prevent prostate cancer? So there's been lots of studies that have been done over generations looking at different medications or vitamins. Finasteride and dutasteride are medications that are associated with like decreasing or shrinking the prostate. These have actually not been shown to help. Selenium and vitamin D have not been shown to actually improve your risk of developing prostate cancer. And then sometimes patients ask me, like, is there something I can eat that will prevent the risk? Like if I start eating a Mediterranean diet, will that reduce my risk of developing prostate cancer? It'll reduce your risk of other things like cardiac disease, and overall improve your health, but it does not affect your risk of developing prostate cancer. So but I tell patients they should eat healthy. Prostate cancer grows slowly, so as Dr. Sanchez touched upon, there's been many studies over many generations where they've done autopsies on men who have died from other causes and just checked their full body to see if there's other things that were underlying at their time of death. So as you can see, as you get older, your incidence of having prostate cancer, be it whether or not it caused you any problems, gets higher. So nearly 75% of the men that they've done autopsies on older than 85 will have prostate cancer. So prostate cancer, most people will die with it, they don't die from it. Most of it never actually becomes aggressive enough to be clinically significant. So this leads us to like the elephant in the room. So sometimes as a urologist or primary care, you can consider over-screening or subjecting too many patients to invasive testing or examinations to find prostate cancer that may or may not actually have clinical meaning in their life. So we have to screen for patients to find the high-risk prostate cancer that if we treat will make you live longer, but we should try to limit the amount of unnecessary screening on most patients that may not benefit from additional testing. So screening. So this is a huge algorithm. I'm not going to go into fully in depth, but this is our new American Urologic Guidelines on how to screen for prostate cancer. I'll kind of break it down one by one. So the first test that all people should get around age 45 is called the PSA. PSA stands for a protein called prostate-specific antigen. It's responsible for making semen actually more liquid. This is our first screening test. You begin at age 45. However, you may consider doing it earlier at age 40. If you have any of the risk factors we talked about, like family history of prostate cancer, breast cancer, ovarian, pancreatic. There's been many trials that saying that screening actually does help and actually prevents your risk of dying from prostate cancer. The biggest trial we had was in Gothenburg. It was a Scandinavian study that screened everybody over 20 years, and they found that by checking everyone with PSAs, you could actually decrease the risk of dying from prostate cancer for about 30%. New guidelines have actually come out that's saying that you don't need to get PSA checked every year. Some guys say like, oh, I need to get my annual PSA and my prostate checked. That's not necessarily true anymore. You can now do it every 2 to 4 years as long as things are normal. You may consider discontinuing screening when people hit age 70. There are other factors that play into that, like your overall health, your life expectancy. In our community, Westlake, Thousand Oaks, Ventura County, people actually live very long. So we might generally continue screening well into your 70s, even early 80s. Believe it or not, the average life expectancy in the United States is around like 77. So that's why a lot of our guidelines say stop screening around age 70. So, but in our community, people live a lot longer. There has been a lot of studies that have shown that if your PSA is less than 3 and you're between 75 to 80, you may never develop prostate cancer that's meaningful, and you may want to consider discontinuing screening altogether. Basically, you have like a 0% chance of developing prostate cancer if you're 75 to 80 with a PSA less than Prostate cancer screening is dependent or how long we are, like the benefits of it are related to how long we screen patients for. There's terms called numbers needed to screen, numbers needed to diagnose. So how many people would I need to screen with PSAs to find one person that has prostate cancer to save their life? With 9 years of screening, that's 1,400. But as you see, as you get older, if you go through 25 years of screening, that number actually goes down to 385. So this is very similar to other cancer screening we do, such as for breast cancer and colonoscopy. The numbers are very similar. And then when do we biopsy? So there's lots of factors that play into your urologist's discretion when they say, like, I think we need to do a biopsy. Those are things like your total PSA number. There's also something called free PSA, which is typically a fraction of your total. We also look at how your PSA changes over time. What's the density of your PSA related to the size of your prostate? And then there's also a digital rectal exam where, when people come in, they say, I need to get my prostate checked. Believe it or not, now this is considered an optional study by our AUA guidelines. If we were to do 45,000 of these exams, we would find cancer in 0.05% of them. So it's not the most accurate study, but we still do it as part of our initial testing for someone who has a high PSA. Then there's other testing with adjunctive biomarkers, which are new and on the field, and then we have our prostate MRI. So I'm not going to go through all these, but there's additional testing that you may want to ask your urologist about if there's something abnormal about your PSA. We have new urine-based tumor markers. We also have other blood tests, such as the 4K score, the PHI, which incorporate other types of PSA. And then we also have tissue epigenetic testing, where they can take your prostate tissue if there's no sign of prostate cancer and give you a risk score depending upon genetic mutations that exist. And then we have prostate MRI as well, which has really significantly changed the scope of urology practice. It has a really high sensitivity for picking up prostate cancer. The main thing we look for on urologists is a specific scoring system called PIRAT scoring. That's associated with the amount of contrast uptake a lesion might show. We have different scoring systems. They might give you a number like 5, 4, 3. 5 is the worst. Sometimes that has like an 80 to 90% chance of finding a prostate cancer. 4 is somewhere between 30 to 60. And then a PIRAT 3 lesion is usually somewhere about 10 to 15% chance of finding a clinically significant prostate cancer. This is helpful for us because it helps guide our biopsies on where to do biopsies. And then it also gives us a prostate volume, which helps calculate your PSA density. So this is typically how we do prostate biopsies in clinic. I do these with Dr. Sanchez. She does these as well. Typically involves an ultrasound probe that goes into the rectum. There's lots of ways to do biopsies now. There's also another technique called transperineal, where they can actually do the biopsy underneath the scrotum through the skin, but most biopsies are done with an ultrasound probe in the rectum regardless. And then through that, we're able to actually visualize the prostate, which is sitting in front of the rectum. There are risks associated with biopsies. Transrectal biopsies are the most common. They can cause some pain. They can cause some blood in the urine. There's a 1 to 3% chance of having a serious infection after having a prostate biopsy. That's related to the fact that the rectum has bacteria. It's not a sterile space. And when we do biopsies, we usually go through the rectum. So there's a substantial risk of having an infection after a biopsy. And then we talk about transperineal biopsies. Like I talked about, these are done underneath the scrotum or underneath the sac. So we basically put small biopsies through the skin. And then this has been shown to have a lower risk of infection, but sometimes it's more painful. Patients might have a harder time with urinating after the procedure.
By like 1%. So 1% decreased risk.
Yes.
Going through the skin versus going through the rectum.
Exactly. So why do we do all these things? So our goal is to help reduce the amount of unnecessary diagnostic testing we do on patients. So we take an entire population of people, we check their PSA. For the fraction of them that are abnormal, we recheck their PSA. If that's still abnormal, we might do adjunctive tests like biomarkers. We then do MRIs, and then finally biopsies. So our goal is to limit the amount of unnecessary biopsies we do on people, unnecessary harm, and find prostate cancer that's meaningful that can help find and change our diagnosis. So Dr. Sanchez.
Yeah, so I'll take it over. So I will say, to summarize the goal in prostate cancer, we know that prostate cancer is a slow growing cancer that tends not to take the life of our patients. Okay, 2% of patients who are followed at 20 years will die of prostate cancer. 2% of patients who are diagnosed with prostate cancer after 15 to 20 years will actually die from that cancer. So that means 98% of men are still alive, even though they were diagnosed with prostate cancer 15 to 20 years prior. So when we are thinking about prostate cancer, there's something called shared decision making. It's in our guidelines. And so we put all the pieces of the puzzle together for the patient. So you come in, patient comes into our office, there's an elevated blood test, and everyone's freaked out about it. And so we say, okay, let's not get too concerned just yet. Let's repeat the PSA typically. Let's get all the pieces of the puzzle together so we can get a better picture of your risk for having prostate cancer that is significant enough to actually treat. So we actually want to avoid diagnosing the low risk, slow growing cancers in the prostate that are never going to cause our patients a problem, because then they have the C word behind, they're now diagnosed with cancer and they're freaked out about it, and it's never going to cause them any problems in their lifetime. So we want to avoid diagnosing those very low risk prostate cancers, and instead we want to maximize our chances of finding the cancers that are significant, that are going to that are intermediate risk or high risk, and that dictate the need for treatment in the patient's lifetime. So once we actually undergo the biopsy, you're going to get a pathology report back, and it'll have a score. There's a Gleason score you may have heard of. The pathologist will look at the cells under the microscope, and the more abnormal the cells look, the higher risk they look, the higher of a number they'll get. So they'll get a 3, a 4, or a 5, basically. And then they kind of, based on their training and just what we know about prostate cancer, they'll give them a score, a 3+3 or 3+4. And then we've even made it simpler for patients to understand. We refer to them as grade groups. So if you're a grade group 1, that's the slow growing stuff we don't really want to get too worked up about. But when we're starting to get to the grade group 2 category, grade group 3 and above, then we're getting into the intermediate risk and the high risk prostate cancer. So you may see this on your pathology report. The other factors that we take into consideration are the PSA range. So as urologists, we categorize in our minds ranges of PSA. So 4 to 10 is 1, 10 to 20 is kind of another tier, and then 20 and above is a higher tier, much more concerning if you have a PSA above 20. But 4 to 10, a lot of guys who do not even have prostate cancer have a PSA between 4 and 10 for benign reasons that we won't get into, but it doesn't automatically mean you have a prostate cancer diagnosis just because your blood test is showing a 5, for example. So we take into consideration the PSA. If we feel anything concerning on that rectal exam, overall it's low yield, but every once in a while we do feel something concerning, so we take that into consideration. These are all pieces of the big puzzle for our patient. Okay. So low risk is typically grade group 1, and you have a PSA between 4 and 10. We watch those. We'll get into kind of what we do about those, but if you are diagnosed with that, then you're considered low risk. Intermediate is when you're getting into the grade group 2s and 3s. And, again, we look at PSA, we look at the prostate exam, and we kind of will stratify you into that intermediate risk category if you have a grade group 2 or 3. Anything grade group 4 or 5, that equates to a Gleason score of 8 or higher, or if your PSAs are greater than 20, these are concerning features, and these automatically put you into the high risk category. And then we can do some extra testing. We would typically get a PSMA PET scan now if you fall into the intermediate risk or high risk categories. That helps. That's a study that is a kind of full body scan that will light up if there's any cancer that spreads to other parts of the body. And then again, as Dr. Katavian mentioned, we do these extra tests that are an option, that are optional for our patients. Some are urine based. All you have to do is pee in a cup, and then we send it to the company. They'll look at your genetics. and they'll kind of risk stratify you. Or there's an option for some companies to get your biopsy samples and run the genetics on your actual tissue as well. So that can help. Again, it's another piece of the puzzle for what we can to help us work together with our patients to provide them with the best management plan. So staging, this is more for this is too confusing, so we don't have to talk about the staging there. So we look at the pathology report. So what do Dr. Katavi and I kind of consider when we're reviewing our path report with our patients? We look at the type of cancer. Adenocarcinoma is another word for the standard run-of-the-mill prostate cancer cell type. There are variant cell types. There are other kind of amorphous variant cell types that increase your risk. You might see something like ductal carcinoma. So if that's on your pathology report, you actually jump a risk category. That's more concerning. It's more aggressive. If you have something called cribiform, that's more concerning, more aggressive. Even if you have a score of, 3+4, just a grade group 2 or 3, if you have these other non-adenocarcinoma cell types in there, they are more aggressive. So we treat them as such. There are some other there's some other terminology or cell types that we might see on the pathology report. Something called PIN and ASAP. Those are precancerous cells, or precancerous. They're not cancer, and we just watch them and we don't worry about those. So this is kind of what you might find on the path report. So once the patient has entered into the intermediate risk or high risk stage, then more often than not, the urologist is likely going to recommend some form of treatment for this patient based on the age of the patient, based on how healthy the patient is, based on the predicted lifespan of the patient. If the patient is not very healthy and has a whole bunch of heart issues and heart attacks and just generally unhealthy, they may not necessarily need to be treated for this because it's not going to cause them any problems in their lifetime. They may have a shorter lifespan than a very healthy gentleman who's their exact same age but takes one medication for an enlarged prostate and otherwise is out playing pickleball and running around and just very healthy. So we would treat those two patients differently. So if you are diagnosed with a low risk prostate cancer, again, those are the ones we actually unfortunately have diagnosed. We went through the process and unfortunately we diagnosed it. So now we got to do something about it. And for those patients, 99.9% urologists who are doing the right thing would put them on active surveillance. That means we simply monitor their PSA, we monitor their symptoms, we follow them mostly with PSAs. Sometimes there might be an MRI every year, every 1 to 2 years, and there might be at some point down the line, typically around 18 months later, again depending on what your PSA is doing, you would repeat a biopsy to confirm the original diagnosis. So it's called a confirmatory biopsy, and at some point, if you have been diagnosed with a low-risk prostate cancer, your urologist might recommend a repeat biopsy at some point down the line.
Something I can add. So like if you look on the graphs on the right, so these are Kaplan-Meier curves, basically the way to determine whether, like how many patients over time are developing some problem. So the top half is how many patients over 17 years, depending on if they have their prostate taken out, they get radiation, or they have active surveillance, how many of them are going to survive? And as you can see, there's no difference in any of the lines. They all are clumped together. So there's a lot of data that supports that if you have low-risk prostate cancer, treatment is actually not going to make you live longer. So we recommend, as a result of that, to just watch it. Now, you can see that on the other graph below it, this is metastasis-free survival. So how many patients, if they choose to go surveillance, will actually have disease progress? There's a small percentage of them that actually do have metastasis over time, but as Dr. Sanchez explained, that half of the patients that choose active surveillance, after 10 years, none of them are going to need any treatment. So for them, we strongly encourage us to keep an eye on it. However, there are factors that cause you to want to consider treatment. These patients are not lost to follow-up, they still follow up with you. That's if their biopsy shows progression or if their PSA starts to rise. Those are things to keep in mind.
So at any point in your active surveillance journey, as we're following you closely and watching your PSAs, you may, and we, say we repeat the biopsy at the appropriate time, you may switch from a low risk to an intermediate risk, and then at that point we would have a discussion as to what treatment options we might enlist for you. So although, and the one thing I'll add to what Dr. Kay said here is that for those patients that have low risk or low favorable intermediate risk, there's no survival difference after 17 years, but those patients are more likely to have a cancer that spreads somewhere else. They're still alive, but now there's a metastasis that we're dealing with. So that's the downs. That was some would argue that is one of the downsides of this active surveillance. But again, as long as we're watching you closely and we act quickly when things change, then patients do very well. So the treatment options for prostate cancer are essentially come down to two main kind of gold standard options still after many, many years. It is either take the cancer out with surgery. Typically it's done robotically these days. I don't know anyone who does it open still. And if they do, then go to a robotic surgeon. And the other option is radiation and plus or minus hormone therapy, systemic hormone therapy. So studies show that both are equally effective for treating the cancer. So they both do the same job at effectively treating the cancer. So one is not better than the other in terms of cancer control, okay? When it comes to prostate cancer treatments, there's a trifecta that we think of. It's cancer control, continence, and erections. It's quality of life and it's cancer control. And those are kind of the things that we keep in mind as we move forward with deciding what treatment algorithm we're gonna pursue. So if we go down the pathway of, you have an intermediate risk prostate cancer, everything is showing that it's still in the prostate, that it hasn't spread elsewhere, and we want to treat it and get it out of your body, then we would pursue with the radical prostatectomy. It's done robotically these days. With the robot, the main benefits are visualization is 10x. There's less pain, there's less blood loss. In some institutions, are even sending patients home the same day. Dr. Katib and I do not do that. We do allow you to spend the night, we monitor, but typically it's an overnight stay, and there's just kind of some belly symptoms and gas symptoms from having the gas in there and the laparoscopic instruments, but patients tend to do very well. We're well trained in this. I mean, this is how urologists are trained these days, is via in all of our residency programs or fellowship programs. Radical prostatectomy is one of kind of the bread and butter mainstays of the surgeries that we do. Dr. Katib and I have done hundreds of them. We offer them at our institution. We have an excellent robotic surgery team there as well. But essentially, you'll have a few 1 centimeter incisions across the belly. We put some gas in. Then we dock the robot, and we're in the same room. And we have one of us typically helps each other out, so you get kind of a 2-for-1. 2 urologists for 1 at our institution. And essentially we move forward with, we're kind of in the pelvis, and as you can see from the photos here, the bladder, we kind of disconnect the bladder from the prostate, and we have a catheter in, and here's the seminal vesicles. This is where some of the ejaculate fluid is made. We work around those, and we kind of slowly, meticulously dissect those out. There's nerves that travel along the prostate, and we, as much as we can, we try to preserve and spare these nerves for the purpose of potentially preserving erections to the best of our abilities. And also, it's been shown to help with urination as well. But we kind of go in and we kind of go across there, get the prostate and the seminal vesicles out. Here's kind of a side view here. We leave the nerves behind, and then And then we reconnect the bladder to the part of the urethra that we, to the other end of the prostate. After it's removed, we reconnect the bladder to the urethra. So, and it's all done very meticulously, 10x vision, with absorbable sutures, and everything degrades, and patients tend to do very well. So, and this is the gold standard of treatment at this point for surgery. The benefits of, I would say, when a patient comes to us and say, well, why don't I just pursue radiation? I don't want to undergo the surgery. They're, like I said, they're both equally effective at treating the cancer. They both have similar kind of cons in terms of erectile dysfunction. The erections do take a hit. It's more complex conversation than that as well, though. But they do take a hit for both modalities. But the benefit of actually the radical prostatectomy is we take the whole gland out, we take all the cancer out. We also go after the local lymph nodes and we make sure that there's no cancer there. So we send that all to the pathologist, and the pathologist will give us, we have a full idea of what this cancer is doing, where it's at, and oftentimes there can be higher grade cancers that we might have missed on the biopsy. So the benefit of the surgery is that we get a full picture of what kind of cancer we're dealing with. We have all the samples there versus just the biopsy samples that we took from your prostate biopsy, and we're making decisions, our best guess based on the biopsy moving forward, versus with the surgery, you have all the tissue out of the body and we're examining it thoroughly. So that is one of the benefits of the surgery. Sexual dysfunction, again, it just depends on what your erections were like beforehand and how healthy you are beforehand. Most men do have restored continence after 1 to 1.5 years. And there's things that we can do to address severe incontinence, but most men recover their continence actually. Anything to add?
No, I mean, I think as far as incontinence, like the reason why men don't leak when they cough or sneeze is because they have a prostate there. And when you remove the prostate, the only thing that preserves continence are pelvic floor muscles that are around the urethra. Women have had to urinate this way their entire lives, so men have to develop like pelvic floor strengthening after the surgery. I sometimes send patients to see like pelvic floor physical therapists before surgery to help strengthen their pelvic floor, because afterwards that's just how they're going to stay dry. So.
There's a whole protocol that we have where we send our patients to the physical therapist. They work with an amazing Australian woman here in Newbury Park who does an amazing job and has a great accent. And she helps our patients train their pelvic floor muscles. And we typically start them on a Cialis, daily Cialis as well for their erections. So that's part of the penile prehab is what it's called. Radiation is, again, another equally effective option at treating the cancer. We do not do radiation. We're surgeons and neurologists, but we have a radiation oncologist we work closely with for those patients that decide that radiation is the modality that they would like to pursue. The benefits of radiation are that you don't really feel any immediate effects. It's non-invasive, and from what I understand, you go in for about 5 days a week for 4 to 6 weeks or so, and you'll find someone locally. I do recommend pretty much all my patients. I recommend that they at least consult with one, because if you go to a surgeon, they're going to tell you about surgery. If you go to radiation doctor, they're going to tell you about radiation. So if you go to the car salesman down the street, he's going to tell you to buy this excellent car. So I like my patients to have the best, the most informed decision. Just all the information at hand. Now, various experiences might dictate whether or not they are really averse to radiation or really averse to surgery. Their buddy down the street had a radiation and it was just terrible, and he doesn't want to get the radiation, he wants the surgery, and vice versa. So I've heard it all. We hear both sides. It cures the cancer. It tackles the cancer just as well as the surgery. And it's less invasive, and you kind of walk walk in and out, and you do very well. Then we would follow you with PSAs. After that, we might get some repeat imaging down the line, an MRI, for example, or if the PSA starts to rise. And then depending on your risk category, if you're intermediate or high, then you may need to also get hormone therapy in addition to the radiation. So,
No, I mean, I think she touched on a lot of it. So radiation is kind of a vigorous outpatient schedule. You need to go to a clinic every day, 5 days a week, anywhere from 4 to 8 weeks. Like she talked about, many patients don't have symptoms related to radiation. The main drawbacks of radiation is that radiation takes a long time for it to affect neighboring tissues around the prostate. So, the goal is to target the prostate, kill the cancer, but there's always scatter associated with radiation. So it can affect tissues around the bladder, such as the rectum, the urethra, blood vessels, and nerves. So patients, even after radiation, will have decline in their sexual function related to radiation of the nerves. There's always a chance, like a 1% chance, the radiation causes another form of cancer, like a colon cancer, for example. And then sometimes when side effects from radiation occur, they happen much later down the road, and sometimes they're much more challenging to deal with. Radiation, after you give radiation, there isn't a final pathologic diagnosis. It's not like you can take the prostate out and say, did I get it all? You basically just have to wait. So we check your PSA after radiation, and it should plateau to a point, and then it should stay low for long periods of time. If PSA was noted to increase after radiation, that's usually a sign that you may have recurrence. Unfortunately, after radiation, when you have recurrence, sometimes it comes back more aggressive. The cells are more radio resistant. And treatment options for patients that have already received radiation are sometimes more aggressive and have more side effects. So that's something I tell patients. A lot of the times I recommend radiation for maybe older patients. Like I explained, more of the serious side effects from radiation may not occur till very long later in life. So if someone is 50 and gets radiation, they may live long enough to experience those side effects, whereas if someone's much older, they may not.
So I tell my patients, like kicking the can down the road. So you're at surgery, taking a hit up front, and you're recovering. With radiation, you kick the can down the road and see what happens. And it's a gift that keeps on giving is the other way I describe it. It can come back and it can cause problems, and you cannot have most urologists cannot take the prostate out at that point because everything's now like cement in there, and there's no more tissue planes, and things kind of are your risk for having major complications increases for a salvage prostatectomy. Here, 0.3 here. But if we were to pursue surgery and things were to come back, then you're still counted for radiation, obviously. So there's different types. Talk to the radiation oncologist about those. Yeah, these are the side effects we touched upon. And then hormone therapy, again, depending if you're kind of a favorable intermediate risk, you may not need hormone therapy. Just radiation may suffice. But if you're, say, high risk and you pursue radiation, then you will need hormone therapy to essentially castrate you to get your testosterone levels down to below 50 because prostate cancer feeds off testosterone. So, and these can have side effects, cardiovascular side effects, breast tissue growth, cognitive mood side effects, mood, almost like menopause, hot flashes, kind of mood, bone health issues, fatigue. So there's some new kind of information out there, some other options outside of the gold standard of surgery and radiation. There are some therapies called focal therapy. This is where, say, your cancer was only on one side and only in one area. You may be a candidate. You may want to talk to your urologist who offers this focal therapy just to that one area. Now, what I can say is we don't have long-term data on this yet. It's not in our guidelines as a treatment option, as a equally effective treatment option just yet. There are a lot of the academic institutions and other places are offering them as an option. We would also, in a situation where we would focally just treat the one area, for example, you would undergo its HIFU is an ultrasound type treatment option. I did a lot of these at USC in fellowship, so they offer them at USC, for example, for guys that don't want to undergo like the whole gland treatment because of the side effects. They may want to just treat that one area. So you go in, it's like into outpatient surgery center. You go under and they would treat that one area with ultrasound, and you would go home with a Foley catheter for a couple of days or so. And then they would follow you like they would on active surveillance. They would follow you with PSAs and follow you closely and retreat as needed. You would still be a candidate for a prostatectomy after like something like HIFU, for example. And what else do you want to add about that?
Yeah, I think focal therapy is like a newer generation of prostate cancer treatment. There are instances where it's a good opportunity, like she talked about, if it's like a small area of cancer on one side. It's not for everybody. I counsel some of my patients that they would be good candidates for it. You can try to avoid bothersome side effects associated with removing the entire prostate and radiation. And then ultimately, HIFU is just one form of energy. It's using ultrasound to essentially heat the prostate and virtually microwave it. But there's other ways to do it. There's also something called irreversible electroporation, which is almost like electrocuting the prostate. There's also ways you can laser that area too with MRI guided lasers. So there's lots of opportunities. Not everyone's a candidate. I try to counsel patients about the risks and benefits of these two. So.
Yeah, and we may be offering HIFU moving forward. We're working on getting that machine because it's a good option for patients with low volume, kind of one area and just in the right location. Mm-hmm. So we're working on getting that at our institution.
So this is a bit of just like a summary slide. So I think this is more to tell you guys like there's lots of options when it comes to prostate cancer. Prostate cancer is also very, very heterogeneous. So there's like many different types and risk categories associated with it. So there isn't like a one size fits all with everybody. Even in some instances, we may not even consider doing treatment if the patient has a lot of comorbidities. So I think prostate cancer is a little confusing for patients to navigate. It's based upon your risk score and then what options are available within that risk score. So I think that's basically it. So we're happy to be here. We're also happy to answer any questions you guys have. Yes.
So what's the difference in mortality between someone who does the radical prostatectomy versus radiation?
There's no, in terms of mortality, it's about the same. There is like a risk of mortality associated with surgery. With radical prostatectomy, it's like less than 0.1%. As far as like mortality associated with radiation itself, very rare and very uncommon. There are risks associated with being on hormone therapy when you're on radiation. So hormone therapy puts you at a higher cardiovascular risk. But as far as comparing radiation versus surgery, mortality risk is a little bit higher with surgery, but overall the risk of mortality with surgery is 0.1% or less, very low.
What else?
You mentioned PIN.
Mm-hmm.
I recently had a biopsy where it came back that I was cancer-free, thank goodness. But he did say, he mentioned, I got good news, bad news for you. Good news, you're cancer-free. Bad news is you have HGPIN. And what are he said the occurrence is like 40% or higher of it eventually becoming cancer.
Yeah, it's considered precancerous. Yeah, and it's not anything we would, again, it's not anything we would have lose sleep over. Okay, it's a precancerous lesion. We don't have the most robust data on these high grade PINs, but it's something that we say, okay, this is more likely to turn into a cancer than just a normal cell. So in that situation, it would make not much of a difference in terms of how we would follow you. I would still check your PSAs. I would not particularly consider repeating a biopsy in that instance. I don't know if you.
Yeah, like to be honest, I think our AOA guidelines explain that you should consider rebiopsy if you have somebody that has high grade PIN. However, in practice, it doesn't really change how we see patients. I still check your PSAs like once a year. Checking your PSA once a year is now considered like a more rigorous screening protocol. The more common guideline now is actually every 2 to 4 years. So I tell guys, you see me every year, we check your PSA, if your PSA were to show that it changes at all, we would consider rebiopsy the lower threshold.
Or we might get an MRI.
Mhm.
So
Well,
if
that's
your
what
PSA goes up, we would get an MRI.
He recommended PSA every 6 months
Mhm.
and MRI once a year.
Mhm.
And then any changes, then perhaps another biopsy.
Yeah.
That's reasonable.
Okay.
I would have
It's
some
more on the
people- yeah.
aggressive side, I would
Yeah.
say.
I don't think there's actual specific recommendations that are saying that get PSA this often, but that is reasonable. It is a little. I think within our practice we're a little bit more lax on it, but totally within reason.
Because again, it's not even the 3+3. We know that with 3+3s, we're watching those anyways.
Yeah. So if you were to have low risk prostate cancer, you would get PSAs every 6 months. You would maybe get an MRI every couple of years, but for like a pre-cancerous lesion, we would. It's not usually as high our concern.
Yeah.
So it is more good news than bad news.
So after he said no cancer, I mean, what could be bad after that?
Yeah.
I got a question. I go to UCLA.
Uh-huh.
As you go up, the PSA is higher, like 6.5.
Mm-hmm.
That's normal.
Yeah, so
If I'm out
PSA is
before-
known. Yeah, so PSA will increase as you get older.
I meant
The range.
range.
Yeah.
So I'm at 4. The 6 is under 6.5. The 6.
So like it's when patients get labs, it'll say like, oh, this is high. It'll say like it'll be marked red or it'll be bolded. So I think that is a little confusing sometimes for patients because PSA isn't necessarily like a PSA of 6.5 for you may be normal if it's always been
6.5 is normal.
yeah.
If I'm a
No,
4,
but what I'm trying to say is that like a PSA of 6.5 is abnormal for someone whose PSA was 5 the year before. But it doesn't show up on your testing that this is abnormal. And sometimes it gets missed by your primary care that your PSA has actually changed. But-
it's always at 4. Then it's a good
So you
sign.
were at 4 and then it went up to
No,
6.5?
no, that's what happened. The range changed.
The actual range on the lab says like
so it
oh,
says
anything greater
says
than
I'm good.
6.5.
Oh,
Yeah,
It says I'm
exactly.
good. It used to be like I don't know. It used to be 4.5. Now it's 6.5.
Yeah. So the range does change as you get older, like the range of what is flagged as abnormal, but I wouldn't let whether or not something bolded on a lab test tell you it's normal or not.
It's changed. It was a big
Yeah, I usually focus my attention on what your PSA has been over many years. But you're right, like as you get older, I'm willing to accommodate like a larger range. So
Yeah.
Yeah, sort of that thing.
And say, for example, your PSA's been kind of hanging around, let's say the 3s, 4s. And then all of a sudden you check it again and it's 7.9. We don't get excited about that. Our guidelines say repeat in 8 weeks. Because for unknown reasons, the PSA will jump. If you've had inflammation, if you've had an illness, if you were on a motorcycle or bike, there's some reasons we don't fully understand. And we just repeat it and moves back down. So
Do bikers have higher PSAs than non-bikers?
So if you are a recreational biker, there was actually like a study done in San Francisco because a lot of people ride bikes to the commute. And there was no difference in PSA for people that commute and ride bikes.
What about people that
So yeah, so
ride
if you
for like 2 or 3 or 4 hours?
So for patients that do like 100-mile bike rides, I generally tell them to not do that right before you get your PSA checked. But it can cause your PSA to go up a little bit if you have like really long-term trauma on the prostate, like biking for 6 to 8 hours. But I have some patients that do that and their PSAs are always a little bit higher. But I would say like if you'd like to ride a bike, that's fine. Maybe don't do a marathon bike race before seeing your urologist maybe. Yes.
We have a question in the chat. So they're saying I have a 3+3 prostate cancer. My MRI was obscured by my hip replacements. Is there any type of MRIs or scans that will bypass the interference caused by these metal hip replacements?
So there are some MRIs that actually include it's like a coil that goes into the rectum. That it's not the most comfortable thing, believe it or not. And then that helps get better imaging of the prostate. Sometimes that can help if you have hip implants. There aren't other imaging modalities outside of the MRI that can be as accurate. So in some instances, the MRI may not be our most useful tool. If the patient already has low-risk prostate cancer, they're typically just put on a screening surveillance anyway. They're being consistently monitored. So they should still be getting PSAs every 6 months. And then our guidelines say you should consider rebiopsying every 2 to 5 years, basically.
Regarding back to the radiation, you mentioned something about some radiation can be focused on just one part of the prostate, and this something new, something, and also something you do it yourself, or what have to do to radiation.
So there is something called focal therapy.
Mm-hmm.
So it's not necessarily radiation, but they're using some form of energy to destroy prostate tissue. So there's something called HIFU, which is high intensity focal ultrasound, which is sometimes an option for some patients that have let's say lower risk prostate cancer, or it's confined to one side, or it's low volume, but they don't have a really high PSA, for example. We sometimes consider it. The places that do it locally, I think USC is the biggest one. Mm-hmm. So I have patients that I've sent there who are interested. Recurrence rates in terms of HIFU versus radiation or surgery are similar if the patients are selected accordingly. So I would never send someone who has high risk prostate cancer to get focal treatment, or someone with really high PSA levels, for example. But yeah. So the idea is that if you have a high risk prostate cancer, you're more likely to have prostate cancer outside of that area we biopsy. So just because your biopsy shows, for example, this area shows prostate cancer, biopsies are never 100%. If you think about it, I'm taking a haystack and I'm poking needles into it, and then I'm finding areas of cancer, but there's always a possibility that another area somewhere else I missed. But with HIFU, I'm only treating one area. Does that make sense?
You want to treat the whole gland. You want to treat the whole prostate.
So what I'm saying, who decided?
Who decides
to go to this particular area? How I know this?
How do you know if you're a candidate for the HIFU, for example?
Yeah.
I think it should be a discussion between you and your urologist. To be honest, I don't bring up HIFU all the time with my patients or focal therapy because they're not usually a good candidate, and prostate cancer treatment is also very confusing. So when I overload patients with options that they may not be a candidate for, it causes more distress. So the problem with prostate cancer treatment is that there's a little too many options. And then now everyone has ChatGPT, and they can ask what is the best option for themselves. And that makes things a little bit more confusing. It's a lot of stuff.
Mm-hmm. Yeah, it's a lot. So. All right. Well, thank you all for coming today. This was it's a pleasure to be out here and just serving our community and increasing our education levels, so there's not false information that is running around. So.
Thank you.
Thank you.
Yeah, thank
for
you.
your time.
And there's some goodies there. There's our cards and our location, and so.
Thank you so much,
Yeah,
doctors.
of course.
Yeah, of course.
We recorded the lecture, so in a few days we'll have it up on our YouTube. So if you would like to revisit, you can go back.
Yeah,
Again.
that's one of the things.
Absolutely, absolutely. And if doctors are okay, we can share is it possible we can share the slides with those that registered?
Sure. Yeah.
Totally great. Well, that'd be great. Perfect. All right. Thank you so much
Thank
again
you
for
very much.
coming.
Thank you
very much.
Thank
Thank you. Have a good day.
Yeah,
and then,
There you go.
the survey in front of you, if you guys have filled it
Who's
out,
your
just
urologist?
leave it at the table.
Yeah.
The surveys that you have, just make sure to fill it out and then
You
you
got
can
the
leave it at the front
trifecta.
table.
Yeah.
So when
Who's your
receive,
urologist?
It should be within a few days, maybe by tomorrow.
Nice guy.
So how
Yeah,
you know to send it in.
So whoever registered, I will go ahead and email it out. Yeah.
Darren's
Did you
never
sign
had
in?
his book.
By any
Now,
chance?
my-
Yeah,
right.
my-
Because he,
my-
yeah,
my-
because,
my-
oh, no, because in the old days, he sees it on the other end. He used to do too much,
I've been
he
reading,
just refuses.
it's probably
I'm
really
gonna get,
dangerous.
I
My wife's a
can't
physician,
do
she
it,
was patient
so if I
sometimes
tell my
with you.
daughter to get it, she
Um,
was
Like,
mad.
give me
Yeah,
a class,
we don't get it, I'm gonna work on.
Because you're mentioning you're just.
I would get my.
Yeah.
Oh, actually, you
Yeah.
mentioned it, yeah, I didn't realize he actually comes out like.
Yeah, so if someone has a diagnosis of
He's out getting a
prostate
higher
cancer that's low risk, we have
PSA.
to make sure
Tell me before
it's
you get
actually
the
low
PSA,
risk, so we
that's,
do
uh,
biopsy
not
that
my
again
fault.
to confirm it.
So.
But yeah,
he
you get it here.
mentioned,
Yeah,
the 6 months.
As you get older, like you're not
Yeah.
And then
past
it
the time.
changes in the next couple of years.
Okay, so.
Should I wait that long?
And then even if.
No, I think that's totally
Once a
reasonable,
year,
yeah.
I
That's also, yeah, it seems like he's watching you very closely.
He's watching me very aggressively.
Have my
Yeah.
number.
Oh, they
don't
okay.
say
Yeah.
That's all.
Yeah, you may be able to push the
Yeah.
MRI out.
Happy
Go ahead
to
and
do
give us
it.
right
You can read the MRI.
As long as your
So you
PSA
get a high
stays
PSA.
stable.
Well, they can do it again.
If
It
there's no
goes
cost
to
for
the fine.
return, you don't have
Stays there.
I'll just mark
Then
that
they
you're
do an
just
MRI
here.
record.
Okay.
And then they can see what's
Go
inside.
ahead and just
And then
record
you do it.
Yeah.
Mhm.
Even then, it looks like
So,
very little nothing. to
when
do.
you do
Obviously,
Yeah.
like to do that.
I've had colonoscopies.
Mhm.
And they give you the IV.
All guys.
Out,
Yeah, and not very
Yeah.
deep.
Yeah.
Eventually,
Mhm.
Why
it
is-
affects you.
why isn't that done? We need to do biopsy.
Why isn't it done routinely for, that's a good question.
Right?
I think
I
that,
have that. I did.
Did it
I
work?
did.
You
Probably don't.
And
Quite honestly, I've never been working.
Okay.
Right now, it's very, very.
Sharon and
strong
I-
goal.
It was probably 3 or 4
He
seconds.
knows his potential, and if he goes down at low PSA, it doesn't work.